Hello everyone, my name is John Levi and I am part of the class of 2022 at the Bowman Gray School of Medicine at Wake Forest University in North Carolina. I will be presenting on research Dr. R.D. Sarwal and I have been working on over the past several months. Point-of-care cranial ultrasound B-mode can detect intracranial hemorrhage with high fidelity. Dr. Sarwal and I have no conflicts of interest to disclose with regard to presented work. Our interest in this topic came from noticing that time-based interventions have not really been created or adopted for hemorrhagic strokes as compared to ischemic strokes. Patients with delayed presentation for large ischemic strokes did not have many therapeutic options and thus very high mortality. This changes with the use of CTA and CTP to distinguish patients with large perfusion deficits without infarcts. For these patients, intra-arterial thrombectomy can now be offered to patients up to 24 hours since onset of stroke, dramatically improving outcomes. Hemorrhagic strokes need different time-based interventions to improve patient outcomes like blood pressure stabilization and reversal of coagulopathy. 30 to 80% of patients with hemorrhagic strokes are admitted to the neuro ICU as transfers from other institutions. So there's a lot of time between when the patient gets on the ambulance and when they are placed in an appropriately high level of care. This is significant because more than half of intracranial hemorrhages expand in the first 3 to 6 hours of onset. Those delays in transport will impact outcomes for these patients. We could target patients for blood pressure stabilization and anticoagulation reversal if there was only a way to diagnose ICH earlier. Currently, diagnosis of intracranial hemorrhage requires a CT scan performed at a community ED or mobile stroke unit. Ultrasound provides an option for early field diagnosis of brain bleeds that can shorten the amount of time it will take for the patient to get necessary care. Once an ICH is diagnosed in the field by first responders, they can target different blood pressures and expedite triage to a healthcare center with the capabilities of managing hemorrhagic strokes. Published literature supports that cranial ultrasound via transcranial Doppler machine can accurately diagnose acute supratentorial ICH that are larger than 1 centimeter wide with greater than 90% accuracy. 80 to 90% of people have thin temporal bones, which we call temporal windows, that allow us to sonograph the brain with clarity. Cranial ultrasound using POCUS machines has a potential of providing us an imaging solution for early field diagnosis of intracranial hemorrhage. This is a synopsis of 10 published studies that assessed utility of ultrasound in detecting ICH. All studies involved formal transcranial Doppler machines. Feel free to pause here to review the information. Here we describe the use of POCUS devices in available presets to diagnose an ICH. You can see the thin temporal window demonstrated by holding a human skull in front of a light source. We position the probe with the indicator facing anteriorly so that we can intonate through the temporal window. The probe can be tilted along the anterior-posterior axis, also known as fanning, and along the superior-inferior axis, also known as rocking, to image different planes within the cerebrum. Below are images of what you would expect to see if you used an ultrasound to image a patient without any acute pathology. The midbrain, contralateral skull, and bony sphenoid wing are used as landmarks to orient the user. One of our patients I wanted to show you is a 64-year-old male admitted to the neuro ICU with a thalamic ICH diagnosed by head CT. On the right is a CT for comparison. The middle image shows our starting place where we orient ourselves in the brain. Again, we can see a midbrain and opposite skull here. The leftmost image is taken when we fan the probe upwards. We see a hyperechoic region of the basal ganglia that correlates to an ICH. You have to be wary of false positives that can look like a bleed on ultrasound. There are areas of the brain that calcify with age, such as the choroid plexus, and if the patient also has a tumor that the user is unaware of, these can show up as hyperechoic regions, which can be confused for intracranial hemorrhages. False negatives can occur if the user is not using proper technique, if the bleed is more than a week old or subacute, or if the bleed is less than 1 centimeter in diameter or very high up in the cranium. Only supratentorial bleeds can be detected with ultrasound. The bony architecture prevents adequate visualization of lower brainstem and cerebellum. So in conclusion, we can reliably detect intracranial hemorrhage using handheld POCUS with available presets. We have now enrolled 12 patients in our study for use of cranial POCUS to detect ICH. More research will need to be done to determine how feasible it is to train paramedics and how reliable they are on a wider scale. So we are continuing efforts to evaluate its feasibility and accuracy in the field. Thank you so much for your time. Again, my name is John Levi, and please feel free to reach out to Dr. Sarwal or myself if you have any questions. Thank you and have a great day.